So we're going to spend the next half hour, 45 minutes, or whatever it takes us or so, talking about one of my favorite subjects, fibromyalgia and small fiber peripheral neuropathy. One of my favorite subjects because it's what we treat a lot, and it's something that we feel we're very comfortable with as far as discussing and fielding questions, etc. I am Dr. Martin Rutherford. I am a certified functional medicine practitioner. My brain must be working today. I'm a chiropractor, 34 years, 35 years. This is Dr.
Randall Gates, board certified chiropractic neurologist, also a chiropractor.
And we have married, we're both chiropractors, but we have postgraduate extensive, I might add, postgraduate education in functional medicine and functional neurology. And individually, these are pretty fun and new paradigms and powerful paradigms for dealing with a lot of the problems that have not been able to be dealt with over the years medically. But what we ultimately have done is married the two. Dr. Gates's discipline largely addresses function of the brain and the nervous system in every facet, and functional medicine pretty much covers everything else as far as physiology, nutrition, gut problems, diabetes, everything you go to your doctor and you're taking pills for. It covers the vast majority of that. So together, we have inadvertently developed a chronic pain practice. Fibromyalgia, small fiber peripheral neuropathy, is also one of my favorite subjects because I got into this not even realizing that I had both of them at the time. Dr. Gates knows that because when he did his neuro exam on me, he was kind of going like, does this guy know he's got all this stuff? And actually, I didn't know it 100% for sure until he did that exam several years ago, but I had kind of suspected on many levels because I had all the symptoms. As a result, when I started really getting into alternative practice for functional medicine, before Dr. Gates was here, I chose to start with fibromyalgia. I figured that was the most misunderstood, seemed to have the widest number of symptoms involved, seemed to be the most confusing. People were having a difficult time getting diagnosed, or for many of you who have it, you probably realize there's even still a question in a lot of doctors' minds as to whether it's a real diagnosis. And then fibro led to a lot of different things, and ultimately it's led to a practice in which we see a lot of fibro. We probably see as much, if not more, peripheral neuropathy. Probably more at this point. And so we'd like to share with you what we know. We are finally in the last edit of our book, if any of you have been watching us for any time, on peripheral neuropathy. And it's going to get there by the end of this year.
Chapter 1 is really good, by the way. We've only retweeted it about 10 times.
So we're perfectionists. At some point, we have to cut this off and then produce a product, knowing that new things might come out a week after we put the book out. But that's where we're at. So we're going to talk about fibro and small fiber peripheral neuropathy because frequently they occur together. So let's get into it for those of you that have not seen our presentation on fibromyalgia.
And this is kind of an update. This is how we're titling it on the web. It's an update on fibromyalgia.
All right. It's an update. So go, but
it largely will concern small fiber neuropathy. We're going to lay the foundation, kind of like we did in the original video.
Okay.
And then we're going to go into
so
really
you can tell sometimes
stuff.
I really don't know what's going on until I sit in the chair, which is one of the reasons that we were 10 minutes late this morning. So okay, well, still, what's fibromyalgia?
Fibromyalgia is where someone has pain all over their body. Lots of times they have other comorbid symptoms like headaches, irritable bowel syndrome, anxiety, depression, things of that nature. But basically, as you know, if you have fibromyalgia, you have this widespread pain throughout your body. Sometimes your clothes bother you, your husband or your wife touches you and it hurts, you have joint aches, on and on and on. So that's basically what fibromyalgia is. And then we're going to take you through how it's kind of evolved as a diagnosis, and how it relates to other medical diagnoses such as rheumatoid arthritis and lupus and things of that nature.
Did you want to talk about the basics of it now or later?
We'll probably go into that later. I'm going to go into that later on, yeah. Yeah.
All right, so let's talk about the diagnosis, how it's evolved. I know that I got pneumonia several years ago, and the next thing I know, I was telling my wife how hard it was to get out of bed. I would say, Nunny, I don't know what's going on, but like every fiber of my body hurts. And I said, it's just weird. One day it'll be there, one day it won't. And I feel like I can't hardly get out of bed. And I was very tired. I suddenly started to become very tired. I started having to really slug it out to get through the days. And then I had a lot of other symptoms that we might talk about later, may not talk about, but I started getting light sensitivity, not really, really terrible, but like a light sensitivity, almost like I had a mild sunburn, and started getting gut problems, put on weight, put on like 30 pounds, and it was going like, what's going on? And I was going through a lot of stress at that time, so a lot of folks just assumed that it was stressful. And I just didn't know. I just knew I wasn't feeling good, and I wasn't really wanting to talk a whole lot about it because it was kind of weird. But it was pretty. It was pretty. It was pretty strange because I didn't look great, but I didn't look super sick either in retrospect. So, in evolving the diagnosis at that point in time, it was still, you're crazy. It's in your head. It's not really anything. It's stress, and so on and so forth. So why don't you talk about that, kind of help these folks to understand how that whole thing came to be?
So basically, it started being acknowledged in the late 80s, and by 1990, the American College of Rheumatology acknowledged the diagnosis of fibromyalgia. And basically, they said, at this point in time, if a person is sensitive to pressure, technically 5 kilograms, but basically if they're pushing on you in 11 out of the 18 points, the points basically consist of here, the neck, the spine, the medial knees, the bottom of the feet, a variety of places. Basically, if you're tender, really tender there, then that means you have fibromyalgia. As long as you don't have rheumatoid arthritis, lupus, other forms of arthritis that would explain your pain. Lyme's disease, things of that nature. So that was basically fibromyalgia.
And that's a pretty poor diagnostic measure.
And because of that, it was considered a diagnosis of exclusion. So most medical doctors would, frequently poo-poo fibromyalgia. And there was a lot of animosity.
So the diagnosis of exclusion means if you go in and they can't tag you with a specific diagnosis and they can't figure out what it was, then they would just kind of divert to, okay, you got fibromyalgia.
Right.
Yeah.
And there's actually a lot of animosity between, at least as it's written in many rheumatology books, between rheumatologists and other medical doctors and the pharmaceutical industry, because the pharmaceutical industry saw that there's this group of people out there with fibromyalgia who had pain, and they'd respond to certain medications. But a lot of the medical doctors didn't really even believe that you had fibromyalgia or that a person had fibromyalgia.
Oh, that was putting it mildly.
Yeah, so I try to be very diplomatic about that, and probably many of you out there with fibromyalgia have felt that. It is still acknowledged in the top rheumatology book that many rheumatologists, those who encounter patients such as yourself, don't like treating fibromyalgia patients, and some completely close their practice off to fibro patients. They feel that they're whiny, they feel that they're semi-malingering, and they're just not fun to deal with.
Right.
Now, there are reasons why you may come off that way, and we're not saying that you're whiny or malingering at all. And in today's broadcast, we're really going to take you through the evolution of our understanding of what fibromyalgia is, how it is caused, how it is real, and some of the new data in the last year, the last 12 months, actually the last 10 months, that's coming out that really substantiates why you have the pain you have. So.
Okay, yeah, and I mean, I kind of didn't go through that because there was so little understanding about it. I didn't really even bother. I understood that there was a lot of poor, in the medical model, that there was a poor approach for chronic pain. I've been a chiropractor for since 79, however many years that is, 35 years. And so prior to, I started out in like doing a lot of nutrition, then I stopped because I wasn't really pleased with the tools. But I've always been in an area of dealing with people with both acute and a chronic pain from a musculoskeletal point of view, and realized that even in that field, chronic pain was like, go to the chronic pain doctor and take drugs for the rest of your life. Which even in that field, back pain and scoliosis and these types of things really wasn't necessary. Probably 80% of the time, the chronic pain could be ameliorated and controlled and so on and so forth. Well, times 10 in my opinion, for fibromyalgia, because there's no test for it. The test that Dr. Gates described is an extremely poor test. If you're, and I wouldn't put myself in the category of a severe fibromyalgia patient where, you know, somebody could hug me, I could feel it, but it wasn't going to like really bother me. But a lot of the patients we have come in here, I mean, you could touch them in 110 different places,
right? Exactly.
And they're going to be tender everywhere, not just in 11 spots out of 18. And interestingly enough, those 11 spots, not to get too off the beaten track here, a lot of them, like the medial knees, it could be like you could have flat feet, you could have tender knees because your knees are
and then a neck and a back
and your hips are pushed.
You're probably going to fulfill the criteria.
Yeah, exactly. So I mean, it's got to be like the poorest criteria on planet Earth. To tell you whether you have fibromyalgia or not. So leaving that in.
I should probably finish with, now we have the 2010 American College of Rheumatology's guidelines, where they have abandoned the aldometry exam. That's the pressure point exam. And basically it's where the person, it's kind of a complicated way to figure it out. But basically the simplistic aspect of it is that if you have chronic pain and it's all over your body and there are no other causes, it's basically justified that you have fibromyalgia, and they have a specific way of saying, okay, is it one extremity, both extremities, how many days a week, how severe, and those are the new guidelines everybody's working with to diagnose fibromyalgia.
Which is still tough.
It's still tough, and what's argued in the rheumatology textbooks is that now it's not a diagnosis of exclusion, and I do like that, because we do know so much about fibromyalgia now that we didn't know in 1990 to explain why the person is suffering with pain. So,
right. Yeah. Well, so what's wrong with these folks? What's wrong with us? Is there anything wrong with us? Is it all in our head? You know, is it mitochondria? Is it parasites? Is it candida? Is it food? What is it? You know?
There's a lot wrong.
Yeah.
And basically what we're seeing is that pain nerves, we talked about nociception in our earlier broadcast this year. We're not going to do that today. Just ignore what I just said. But basically, your pain nerves, they respond mainly to two things. Inflammation from the immune system, most commonly, as well as...
In practice, about 90% immune system right now for that reason.
And then stress, hormones. So commonly, fibromyalgia patients have been through severe stress, many times abuse as a child, abuse as an adult, unfortunately less of the time sexual or physical, and because the brain gets so fired up in those abusive states, basically the brain gets used to pouring out lots of stress hormones. And it's readily acknowledged in the fibro literature that many have been through these atrocious events in their lives.
Your brain can only handle that abusive state usually for about 20 minutes, maybe 30, and then there's a couple things in the body that kick in to shut it down. And for people who have fibromyalgia, yours doesn't shut it down, and you're in that mechanism to some degree 24 hours a day.
Even though you may not feel stressed, and you may say, well, it happened 20 years ago, and I have fibro now, but I've dealt with it. Well, it could be a huge piece of your condition because the stress hormones are still flooding.
Yeah, it is. Every fibromyalgia patient that would come in here has had that as part of
the stress response. Not all have had the abuse, but many have had the abuse, and frankly, it's nauseating.
Right.
And basically, nauseating that humans do that to each other. So basically, the stress hormones flow throughout the system. They bind to parts of the spinal cord, and that causes the pain nerves to just send more and more signals to the brain. And then we have this balance. Most of you don't know that our brain is actually shutting off pain from our body all the time. That is actually how morphine was discovered.
If it wasn't doing that, you couldn't put your socks on.
Yeah, exactly.
It would hurt.
We discovered morphine because our brain produces morphine, just so you know. So all of you out there taking Percocet or oxycodone or OxyContin, things like that, that's working on a natural chemical that we have in our body. And so there's this balance between what our brain is doing, shutting off pain, and then pain coming into our body. But the problem is if you've been under stress for so long, now your pain nerves are like raging. They're on fire. So as a result, your brain can't shut it off, and this balance gets shifted. And then your brain starts learning that pain, and your brain can't shut off that pain. And then you start focusing on the pain. And they've actually done studies that fibromyalgia patients who have a supportive spouse who says, how are you doing? How is your pain? They actually do worse than those who don't have a supportive spouse, because the supportive spouse is causing them to focus on the pain, which is just
a new piece
so
of data
interesting.
To me. Okay.
It's so interesting.
Holding out on me on that.
I haven't brought that up.
No.
Okay. Yeah, it's great data. So,
we're going to kick everybody out of the program as a supportive
well, they need a supportive spouse relative to the diet, but just don't ask about the pain levels. We'll do that.
There you go.
And then
It's important to have a supportive spouse.
Yeah.
Trust
On many
me.
levels.
Yeah.
So also, yeah, have a supportive spouse, but don't ask about your pain. So then also, relative to fibromyalgia and the pain, the immune inflammation. And this is something that's being more and more acknowledged. We talked about an article out of, I think it's Clinical Rheumatology, January this year, where they were talking about Hashimoto's thyroiditis, which
that's
is
where I was going.
where the
I
immune
have
system kills the thyroid.
Yeah.
It's called Hashimoto's thyroiditis because Dr. Hashimoto put his name on it. He identified it. And with Hashimoto's thyroiditis, we see that a lot of fibro patients have Hashimoto's. And they're now saying that the immune inflammation from the Hashimoto's attack to the thyroid, it's not just to your thyroid, the inflammation is throughout your body, kind of like when you have a cold and you're sick. That inflammation causes the little nerves that go into your spinal cord that carry pain to, again, send way too many signals to the brain.
When he says a lot, I mean, it is a rare fibromyalgia patient that comes in who does not have Hashimoto's.
Many do, and you know, we've read studies upwards of 15% of the female population have a very high level Hashimoto's response. And now there's a lot of debate in the literature as to what the high level, meaning how many immune cells to the thyroid, is normal. And some people are saying it should be up here, and some people are saying it really should be down here. And if it is true, we are more on the lower end.
So fibro,
You may be looking at a huge percentage of the female population.
So in fibro so far, we have the sensitivity more than in 11 spots. We have a brain that's going 24 hours a day, and you're not able to block out the pain anymore. By the way, that stress response, frequently you can almost trace it back. A lot of times the stress response will set the symptoms off. But you can have a long-term stress. The gentleman we had in here yesterday,
Yeah.
the guy's ex-Marine, 4 years in Iraq. He also was in the Gulf War. I mean, I don't know how this guy did it, but he just had a chronic stress, just beating him down. Never knew who was going to shoot him, all that type of stuff. Bad deal.
Yeah.
So you got the stress response. Most of our patients either have Hashimoto's, or a small percentage will have some other thing wrong with their thyroid. They'll have the sensitivity.
Or they may have other autoimmune problems that don't fit rheumatoid arthritis or lupus, but they have this immune inflammation.
They might have other autoimmune problems,
Yeah.
and generally a gut that's kicking up on them.
IBS is really common.
Yeah, that's if you have that, you could probably check off fibro when you come into the office. Those are the things that evolve into this, and it's a little different. The symptoms are slightly different for everybody, maybe drastically different for everybody. Maybe some people are really sensitive, some people aren't as sensitive. But the bottom line is, it's going to be somewhere in that box is going to be the answer to your healthcare problem. So,
and there are a few other things I want to say on that point too, just to finish up.
okay.
So the literature has also shown patients with fibromyalgia make antibodies to serotonin
Okay.
4 times more than control subjects.
Okay.
We also know that if we inject,
So they're not happy campers.
and that's lots of times why they're put on things like Prozac or other serotonin-based medications to help them feel better. We also know that fibromyalgia patients, you can inject the hormone from the brain to the adrenal gland. Lots of times the adrenal glands won't respond, even though their adrenal hormone levels are normal. Same thing with the thyroid. So there's these new endocrinological problems, meaning hormone problems with the fibro patients that are acknowledged, but we don't really necessarily know what to do with them yet because it's completely counterintuitive to what typically happens when somebody has an adrenal gland problem or a thyroid gland problem. Basically, it's like a resistance where they don't respond to the brain signals to those glands.
Yeah.
And we can go on and on, but those
I was
are
going to say
those are
those do kind of
nuances.
fit into the paradigm.
They do.
That we just outlined.
right, exactly.
So you have down what was the understanding of the causes of fibromyalgia before?
That's basically
13? I think we
those
kinda
are basically
went
them.
over that. So, and now to go on, the title of this was Fibromyalgia and Small Fiber Peripheral Neuropathy, and I have that too. I'm kind of like the poster boy for this, but it's been kind of good to be that. I feel really good, by the way, right now. I mean, I probably have better normal days than most people that don't have any of this stuff. So, and I work pretty consistently and hard, and I have a normal life, and I feel good, and there's a few things I got to do to maintain that, and it's been really it's actually been interesting and on some days fun going through all of this to get to where we are right now. One of the things that I didn't realize until Dr. Gates evaluated me about 4 or 5 years ago was that I not only had fibromyalgia, I kind of knew I had fibromyalgia. I'd read about it, that type of thing. I'd had patients who had it when I was a chiropractor, but I didn't know that I had small fiber peripheral neuropathy. I just thought that the hair was off of my legs because I used to play baseball. I just thought, and I was getting to the point where I was actually having a little difficulty walking because I didn't realize I was losing my gait properly. I would go out to the golf course and if I walked 7 holes, I had to sit down and then get up again and so on and so forth. I had no idea I put it all on whatever it was that we were calling the fibromyalgia.
Mm-hmm.
And then you evaluated me and said, wow, you got fibromyalgia too. And so we have seen a substantial portion of the patients who come in here who have fibromyalgia have peripheral neuropathy also, which led to the investigative Sherlock Holmes here looking into that. And why don't you share with these folks what your findings are?
And that's a great point, because for years we were seeing these signs of peripheral neuropathy in fibromyalgia patients, and it wasn't acknowledged in the literature. So I was thinking, boy, is this, what's going on? Is it coming from the lower back? Am I missing a diagnosis here?
Right.
And then it really came out last June, but it was the November journal of the journal Pain, to pretty substantial journal in the pain world. It's pretty much the gold standard. And they said objective evidence that small fiber neuropathy underlies some illnesses currently labeled as fibromyalgia. I think that's an understatement, because in their article they went on to say that 41% of fibromyalgia patients that they looked at had evidence of small fiber neuropathy or were clinically defined as having small fiber neuropathy. And they excluded other small fiber neuropathy cases. So basically it wasn't like somehow these small fiber neuropathy cases ended up in the fibromyalgia group. They made sure that that was not the case.
Right.
And that was a big, big deal, because small fiber neuropathy basically involves the nerves that carry pains. So peripheral neuropathy is where the nerves start to degenerate in the feet, the hands. The nerves that we have that go into our legs and our arms are very large, and they have many different types of nerves composed in them. Some nerves are big, and they tell us which direction our joints are moving. They control muscle function. They help us to have reflexes and things of that nature. The smaller nerves code pain and temperature. And in certain neuropathy conditions, selective fiber types will degenerate, meaning the big fibers will die or the small fibers will die. And when the small fibers die, lots of times that's associated with pretty horrendous pain. So they came out and they did the diagnostic studies on it and showed that 41% of fibro patients had it. Then in July of this year, brand new article out of the Journal of Arthritis and Rheumatology, another pretty foremost or paramount journal in the pain world, they said that all patients with fibromyalgia had evidence of stalking hyperesthesia. That's what Dr. Rutherford had in his examination.
Right.
It's okay, I can say that. He's given me HIPAA clearance. And this is what we were seeing in our examinations. And basically, stalking hyperesthesia is that as you take the pinwheel down or you poke the person down their leg with a needle, all of a sudden they start saying, ow, 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 once you go past their knee or you go past their ankle.
That's what I did.
And that is a sign of small fiber neuropathy.
Which was surprising to me. I really didn't realize it until they started doing that.
And they had a pretty good sample size here where all of them had that clinical finding. And then they went on to do other tests for small fiber neuropathy and saw a huge proportion of them have small fiber neuropathy. So that's a big, big, big finding. And they're thinking now that it's due to the immune system. The immune system is the primary cause of these fibromyalgia patients having small fiber neuropathy. So we wanted to do, and there's one more article we're really going to talk about here, but we wanted to do this update. We've talked about small fiber neuropathy in the past relative to this journal article out of Pain, but more and more is coming out now that's really substantiating there are major things wrong. There are major things that are wrong with fibro patients. And as you've said, fibromyalgia is a horrible diagnosis because you think, oh, I have pain in my muscle fibers. There's really not much that's wrong with the muscle fibers.
The pain management diagnosis.
Yeah, exactly. In fibromyalgia patients, fibromyalgia is
there's
more,
nothing wrong with the muscle fiber.
It's really more a neurological problem,
Right, which is why he's talking about it.
exactly, which consists of small fiber neuropathy And also the fact that now your brain becomes accustomed to the pain because it's getting so many pain signals. And then also autoimmune problems.
And I was just going to say that it's caused and exacerbated by an autoimmune problem that continually gets fed by whatever you're doing wrong.
Yeah, and I just
sugar,
think
diet, food allergies. This is where all that other stuff comes
that we
in.
do that comes
And
in.
I put that in because I know a lot of the fibro patients come in and they've been exposed to the paradigm of, oh, it's all parasites that cause this fibro,
Right.
or it's all candida. And then they get something done, they feel better for a while,
Huh.
and then they're all excited, and then it comes back, and they go, why? Well, it's because it's way not that simple. But that can be one of the triggers to the immune problems that Dr. Gates is talking about. So you have a combination of the neurology and the functional medicine in a sense that you have a combination of the brain overfiring and the nerves dying and the nerves having issues, and then you have these metabolic issues that are there contributing to some of the symptoms, but contributing to the damage. And ultimately, if you're not aware of what you're doing to perpetuate, most people seem to be aware of the fact they're stressed out of their mind and just can't know that they can't do something about it. Most people come in here, most don't have a clue they have an autoimmune problem.
Right. Yeah.
I think that's kind of what I wanted to bring out here, and that's an awareness that I would want to bring out. And I don't know if that's where you're going. Also, when we talk about what does it mean to the fibromyalgia patient to have peripheral neuropathy, or what does it mean to the peripheral neuropathy patient to have fibromyalgia relative to treatment? That's kind of an interesting question because a lot of people watching this may not even know that there are successful treatments for fibromyalgia or peripheral neuropathy.
Right, exactly.
So,
well, one thing I want
to tackle that.
I will, and first thing I want to interject is that when I first started into practice, you had talked about how in your 30 plus years at that point of dealing with back problems, that you would see things clinically before they would come out in the literature.
Always. 5,
And
6, 10 years.
this has been a neat kind of example of that for me because we've been seeing these autoimmune problems as well as neuropathy issues with fibromyalgia patients for years now, and treating them and then or managing them technically, and then seeing really cool results, very successful results.
My first exposure to somebody having dramatic changes in their physiology by getting off of, at the time, which is called wheat, was in the early to mid 80s. And this celiac gluten thing is just now really come out in the last couple of years.
Right. And so anyways, that's neat. So relative to what does this mean? We presented an article and we put this on Facebook, and you can find it on our Facebook page, where it came out of the Annals of Neurology, February this year, where they say hyperexcitable C nociceptive fibers and fibromyalgia. What that means is that the pain nerves are too excitable, basically, in fibro patients. And they did this really cool technique. It's called microneurography, where they can go into a pain nerve and see how it's discharging. And they went into people who didn't have fibromyalgia, and they saw that the nerves were discharging normally. And then they went into fibromyalgia patients, and they saw that this thing called a silent pain fiber was way overactive and abnormal in fibro patients. And then another type of pain fiber was also abnormal in fibromyalgia patients. Perpetually
activated.
Sending weird signals, as well as in small fiber neuropathy patients. And we now know those two groups overlap, and they said this is a landmark study because it had never been reported. So again, it's another piece of information down the line that fibromyalgia, again, is really a peripheral nerve problem. You heard it here first, which then causes your spinal cord and your brain to learn pain.
You want to define peripheral nerve?
Peripheral nerve is where the nerves that come out of your central nervous system, central being brain and spinal cord. Peripheral nerves are the nerves that go into your upper extremities and your lower extremities.
Yeah, all the nerves that aren't your brain and your spinal cord.
And what we're seeing now is that it's a peripheral
problem.
nerve problem because the small fiber peripheral nerves, the ones that encode pain, are either dying, they're sending weird signals to the brain, or both. And as a result of that, you're feeling so much pain. So that's why you're in so much pain. And relative to treatments, we're writing a whole book on peripheral neuropathy success stories, because everyone out there with peripheral neuropathy is told, or pretty much everyone, if it's not diabetes, we don't know what the cause is, or maybe it's a vitamin deficiency, and basically you got to live with it. Here, take this medication, and that's not a denigration. Good thing if the medication works, but we have, through our training and then development of our tools, seen very, very neat responses with peripheral neuropathy after we properly select patients.
Yeah, we've seen consistently successful results, and we do good screening. But I mean, we have a very occasional failure, but it is.
And I think it's largely predicated on our screening procedure.
Yeah.
That's why we see so many positive results. And basically, what you need to know is that things can be done out there for peripheral neuropathy. That's what the literature is showing.
And fibromyalgia.
As well as fibromyalgia. And so if you can get these small fiber nerves to start not dying, so you get the immune system to stop attacking them, which is basically the autoimmune problem we're talking about. And then if you can go in and resynchronize them, kind of like shocking a heart back into life, and get them to send normal signals rather than, because nerves are just like Morse code. If you're getting the wrong code, your brain interprets that as pain. Whereas if it's sending the right signals, then your brain may perceive that as not as painful. And so if you can go back and resynchronize the nerves and calm down the autoimmune problem, you may be able to help the peripheral neuropathy. In this case, that's really important to the fibromyalgia patient. And so, yeah, that's...
Yeah, and having seen this evolve from understanding fibro is mainly, my understanding of it initially was mainly an autoimmune problem. Gates and I joined forces, and then Doug Gates began to realize that there was a strong neurological component from stress mechanism. And then we evolved into putting together a stress modification program for the patients that we were working with fibromyalgia. And then ultimately ended up realizing that you had to have a stress modification program, treat their immune system, and treat the peripheral nerves. And that's peripheral neuropathy, and that's fibromyalgia. And so that's the evolution that Dr. Gates is talking about. And I can look back to when I was first treating fibromyalgia patients before he got here. And there's a lot of those folks, I think you said possibly 41%.
Mm-hmm.
You know, in retrospect, a lot of those folks would have been helped more had we known that, and had we dealt with the peripheral neuropathy, or frankly, even the stress mechanism,
mm-hmm.
because we weren't really even dealing with that. The stress was getting knocked down to the degree that could get knocked down by calming the immune system and the inflammation in their gut and all that type of stuff. But they were having these significant ups and downs relative to treatment. And Dr. Gates realized that it was the stress mechanism that wasn't being handled. And then as we started to handle it, he started to come up with strategies for that based on some of his teachings and research. Then we realized even more how important it was. They would put a whole stress module in for the fibromyalgia patients, non-drug, I might add. And yeah, it's been quite a ride, but I feel like we have a pretty good grip on it now, so we felt comfortable in doing an update here.
Absolutely.
On it. And you can look back at our fibromyalgia. Wow, that was less than 6 months ago we did.
It was about 6 months ago.
The fibromyalgia presentation. And we've done a presentation on stress, and the book is Why Zebras Don't Get Ulcers by Dr. Rob Sapolsky. I don't have a great short-term memory based on also having a bunch of concussions, but he's mentioned that book so much that I even remember that book and the name of the gentleman and where he practiced or where he teaches at Stanford and so on and so forth. Top expert in the world on stress. So you can access those, but I think that pretty much covers what
yeah, I can't stop perseverating on this one article. 41 consecutive patients.
Perseverating means you can't let it go. You just keep thinking about it.
Stocking hyperesthesia. Oh, one thing I want to say is that there's this new scale. So in our book, we talk about small fiber neuropathy. And a lot of
this is why we don't have a complete book. Oh, there's one more thing we got to put in there.
Also because I can't bring it down.
Also because I have to translate it into English. Yeah.
So anyways, on small fiber neuropathy, a lot of the data came out of Utah. 2 gentlemen who were really discovering small fiber neuropathy. And they came up with the Utah Early Neuropathy Scale. And the Utah Early Neuropathy Scale is basically stocking hyperesthesia. And they're saying that is a very sensitive and specific test for small fiber neuropathy. So there's the question that, you know, we brought up 41% here. They're saying all of them have this. It may be higher than half of the fibromyalgia patients have small fiber neuropathy.
Because the testing is done now doesn't show small fiber neuropathy
right,
all the time.
Exactly. So it's really opening up kind of what our ideas of small fiber neuropathy relative to fiber. So it's very exciting. We're glad you watched.
And if you have any questions, if you watched this and you have any questions, because so many of the fibro patients as well as the peripheral neuropathy patients have so many different things going on. Feel free to let us know. Feel free to contact us by email. Send it. You can contact us at powerhealthtalk.com.
Mm-hmm.
I think you say Facebook.
Yes.
But they would send it to powerhealthtalk.com.
Powerhealthtalk.com. You can go in there and write your comments, or you can go to our Facebook page, or you can post it on YouTube, because this will be on YouTube here in a little bit as well.
Okay.
Okay. Thank you for
Hope
watching.
that was valuable, and see you next time.